Also seems important, I just wanted to note that the work I'm going to describe is the work of many people and involves active collaborations both with David Rowe here in Israel, but also colleagues in Italy and throughout the United States as well. And I also thought I might mention a little bit about myself and this sort of work. In addition to doing research and regular academic activities, I also meet with individuals with severe and persistent mental illness, adults, and spend a considerable number of hours every week in a clinical position, meeting with human beings who are struggling with these issues. And I hope that in this talk today that some of the things I've learned from those conversations will come through and inform the academic research. So in terms of an outline, I was hoping to really cover three things. We'll see if the time permits, but at the very least to talk some about research on stigma and how it's related to the lives of individual human beings. Heard quite a bit of important information about larger societal problem of stigma and the definition of stigma, but I'm hoping to talk some about how stigma infiltrates the lives of individual human beings. So beyond the general abstractions of stigma as phenomena, in terms of an individual person who goes about their daily life, how does stigma really interfere and surface? And then I hope to be able to offer a little bit about implications of this understanding for treatment and rehabilitation practice, as well as evolving directions. So as you've already heard several times today, stigma refers to stereotype beliefs about persons which are based on personal characteristics, and certainly, at least in the United States, the big two forms of stigma are: if I have a mental illness, it means that I'm dangerous, or if I have a mental illness, it means I'm incompetent, I can't manage my own life. And so, to begin with the question of how in the world does this emerge in the lives of people, how do these things seep into the identities of human beings, I thought I would say a little bit about some people who I've worked with and who I know, and I'll disguise their names and other information. But I think of a young man who I'll refer to as Strauss, and he's, as I mentioned, a younger person. He has schizophrenia, is enrolled in college, but really is struggling with some significantly disabling symptoms. But independent of those symptoms is at the root of what this young man runs up against are his beliefs about himself and who he thinks he is and what he sees as the meaning of his life. And so as a beginning to think about how stigma infiltrates the lives of persons, I'll tell you about a very first meeting I had with Strauss. And so we sit down, and I have an office in a hospital, and he comes in to consult with me. And we're talking, and he reaches into his pocket for a piece of gum. And he says, "Hey, don't worry, it's gum. It's not a knife. It's not a gun." And so, of course, I thank him because I say, "Thank you. I'm terrified of gum. I'm glad that you helped me to be a little bit calmer." But what this certainly leads to in a very early part of my consultation with Strauss is the basic idea that this man believes that he'll be seen as dangerous, but there's also some sense that he might even be dangerous to himself. He's considering transferring universities to study something that he's a little more interested in than the particular field of study. And so this would mean moving to a different city. And so as his consultant or therapist, I say, "So you're going to move, you're thinking of moving, you're telling me." And he says, "Well, no, I couldn't really move. I'm not sure I could function like that. This is a guy going to college. And what do you mean you can't function?" He said, "Well, I'd have to get a new apartment." I said, "Well, of course, yeah, you can get a new apartment, but you're not thinking of that." And what emerges pretty rapidly is the sense of Strauss that he couldn't manage his own apartment. I asked him, "In what way? Will you accidentally burn it down, or paint it strange colors, or why couldn't you manage your own place?" And he really initially has no answer other than this very root core and unquestioned belief that he can't manage. that he's incompetent, that he's in some way dangerous. These sort of beliefs infiltrated at an even deeper level. As a bit of a confession, I can be kind of pushy as a consultant, and I'm sort of pushing him to think about things. And he comes in one time and he's quite angry. He begins by saying, I just want to get this clear. My goal in life is not to go to jail. And that's it. And so clearly the message is, of course, stop pushing. I inquire, how come you have left out the kissing pretty girls part? And he says, I told you, no. This is about, I'm not going to go to jail. So the story moves on for Strauss in many happier ways, but I tell you the beginning parts of my conversations with him as an illustration for how even when interacting with me, hopefully a consultant who's respectful of him, I'm a dangerous person, he thinks, I'm incompetent, don't ask a lot of me. This whole idea of making life plans, I'm not sure that I want to go there. And then I think of a different person, an older man, someone more the age of Professor Link, or Professor Rowe, a little bit older than me, who has struggled with schizophrenia for much of his life, and I'll call him Glass. Again, the details are disguised, but Glass essentially tells me that he's empty, and he doesn't know what to do. He lives in a cloud bank, and he's not sure what to do. And again, as being somewhat of a pushy consultant, I keep nudging him and saying, but you told me you went to a party and there was a woman playing ping pong and you thought she was attractive. I mean, if you're empty, how'd you figure that out? And Glass, who has a sense of humor, laughs and says, well, I've been taking vitamins. And so, but as we talk, I push him more and more, and he finally becomes, well, you get angry with people who push you. He gets a little angry with me. And he tells me a very painful story which essentially is, he says, my emotions are dangerous. And he tells the story of how he, 5 years earlier, had run from his home naked. He'd taken his clothes off and he'd run out of his house. And he more or less looks at me as if to say, okay, Professor Lisaker, you're an important doctor, now what? I've run out of my house, out of control, and I'm naked. And don't you see? Of course he's saying, don't you see I'm dangerous? I'm incompetent, my emotions have no meaning. And so my response may rub you the wrong way. You may not agree with my style, but as a pushy therapist, I say, okay, so you want me, Mr. Glass, you want me to know that you've run from the house and you're naked and you're crazy. And he's like, yeah. And again, very challenging. I said, well, so okay, how far did you get? How far did you run? He says, well, I got to the edge of the yard. I said, well, was that like 1,000 yards or 500 feet? And he's like, no, it's just like about 20 feet. And again, being pushy, I say, well, but you're naked and crazy. Like, how come you only went 20 feet? That's kind of wimpy for naked and crazy. And what we end up discussing is that, in fact, his going out naked was something he was very embarrassed about. And, you know, again, you don't want to see Mr. Glass or me naked in public. That would be very distressing. But regardless, as we talk about it, this act, as embarrassing as it was, had meaning for him. It was something that he did in an extreme way to say something at a period of great turmoil and trouble. And so, in addition to feeling incompetent or dangerous, I think Mr. Glass is saying, my emotions have no meaning. My behavior has no meaning. I do things, it's dangerous, it's out of control. Don't push me. I think much like Mr. Strauss. I'll tell you a bit of the happier ending of Mr. Glass. So in the consultation work with him, he decides he'd really like to date. And like many people in America, he takes out an ad in an internet dating service. But, you know, he describes himself as disabled. I don't know if he uses the word schizophrenia, but he might as well have presented one of Professor Link's vignettes to describe himself on his dating service. And but I ask him, like, why do you say such things? You know, there's so much more to your life that you've told me. This Mr. Glass actually is a very accomplished photographer. I said, you could mention that. All these other things. I say he's actually a computer nerd. So you could say that you're a computer nerd. And he says, well, I'm not telling anyone I'm a nerd. And I explained to him that I have a 15-year-old daughter who's very beautiful and has told me that I'm a nerd, but that's okay. So these sorts of challenges really, I think, unearth these deep-seated beliefs that have crept in and infiltrated the core identity of these two men. Mr. Glass actually had a very successful romantic relationship and has discontinued his consultation with me and is doing well. And I think if there's something perhaps that was involved in that work, or that's involved in the work of Mr. Strauss and many others, again, is these beliefs that were so beautifully outlined in Professor Link's slides. These beliefs come to dominate the core experience of the person. And so, of course, housing, jobs, medical care, legal representation, friends, these are all compromised by stigma. But sort of who the person is as a being in the world comes to be changed and defined. And those are essentially the research interests that I've come to embrace, and that I want to talk a little bit about. The notion that if this thing seeps into my being, if I define myself as my illness, that I won't expect to succeed, I'll see very little hope ahead of me, and I'll view myself as somehow less than I used to be. The human being I used to be will have been changed. And I would borrow a term from medical research, autobiographical disruption, or sometimes called biographical disruption, that all of us early in our lives have a sense of our story and where it is that we're going to head and who we are and where we're going. And perhaps underlined here through self-stigma, through the impact of stigma, is that biography or that autobiography becomes shattered. Not just changed in trajectory, but in some way almost kind of challenged with obliteration or destruction. A particular man I worked with was going to be a math teacher. It was somehow completely irrelevant once he became ill, totally wiped away, and there wasn't much of a sense. A teacher, a psychologist, any number of dreams or hopes, a vision of oneself as emerging in a trajectory over time, a story. That story gets disrupted as stigma is incorporated. So, and of course, with these sort of core beliefs, then it's not really a surprise, as we heard in one of the early remarks, that even when symptoms have remitted, people find it difficult to continue to work or to go back to work, to form social relationships, and to even have a sense of oneself as able to make one's own decisions or beliefs. In the work with Mr. Glass that I told you about, the guy who ended up with a happy romantic relationship, much of what he ends up coming to talk about is how angry he is and how belittled he felt in some of his early hospitalizations when he felt coerced and forced to receive electroshock therapy. And this sort of sense of himself as having lost the ability to make his own decisions or to, in some ways, decide himself what he believes about things, to be the author of his own life story, to create a picture of what he believes, and then to share that in a back and forth way with other people. So let me move on then to some of the academic work, with those hopefully as an outline to give some sense of what led me to the questions I'm going to ask. And so, as you've already heard, people who report that they've experienced stigma, people who report that they have accepted in some way stigmatizing beliefs, feel poorly. It's not terribly surprising. In fact, it would be shocking if that wasn't the case. So I was interested in a study in which I was interested in the question of whether or not stigma then also though predicts feeling poorly in the future. So it doesn't, even independent of how I feel today, if I have a mental illness and if I have really run up against stigma, will I feel poorly 6 months from now? Does this really project into the future? And so this is a study that we published in 2007. And so the design of the study was relatively simple. It was really simple. At one point in time, we measured 3 kinds of symptoms of schizophrenia. And Those are positive symptoms, which are symptoms like hallucinations or delusions. And by measuring this, we are doing an interview and trying to gauge how severe those symptoms are, from a high level to a low level. Negative symptoms, we also measured. This is the absence of interest, of drive, of emotion, of speech, of thought, a kind of inner deadness. And again, that's measured in interview. And we also measured emotional discomfort, which is to say anxiety and depression. And we assessed these symptoms in a group of patients suffering from schizophrenia, along with a measure of stigma. And we used a self-stigma scale that Dr. Flynn, who's going to speak later, also helped develop. 36 people, not a ton of people, but some. And what you see in this slide are a series of correlations. And I'm going to try and operate this. And if I shut off the power for the entire place, you can blame Dr. Rowe for having invited me. Aha, all right, better than I thought. These first batch of numbers here reflect correlations between to what extent, if I experience stigma, do I also have higher levels of symptoms? And so as you'll see, if I have high levels of stigma, if I report high levels of stigma, at the same time, I'm more depressed, and I also have higher levels of hallucinations and delusions. Again, unusual beliefs or hearing or seeing things that other people don't necessarily hear or see. Replicating previous findings. Of interest, though, is does my report of stigma predict later what level of symptoms that I'll have? And so here you'll see 6 months later, if I have high level of stigma, 6 months later I also have higher levels of positive symptoms later on. I also have higher levels of emotional discomfort later on. That's 6 months later. So there indeed does appear to be some lasting impact of stigma over time, not just in the moment, but symptoms later. And you might wonder why would stigma be related to things like hallucinations or delusions? And we would offer the hunch that it may be that people who experience higher levels of these especially visible symptoms are more prone to be the targets of stigma. A key thing that I haven't told you yet about this. So how stigmatized I feel now predicts how depressed I'll be 6 months later. Statistically, we covariate out the impact of initial level of depression, which is to say that if mathematically you make everything equal, that you wipe away all the depression you have at the beginning, the people who are more stigmatized when the assessment is given are still more likely to be depressed 6 months later. In other words, it doesn't even matter whether I'm depressed today or not, but the exposure of stigma predicts greater levels of distress in the future. I think, again, very well echoing some of the earlier remarks that as the illness fluctuates, as people's symptoms remit, as they feel better, the core of stigma remains and remains distressing and limiting to people. If you're curious, if you wipe out the difference in positive symptoms, stigma doesn't predict more positive symptoms 6 months later. Again, perhaps speaking to the possibility that these are symptoms that are more obvious to people and are more readily markers for the illness itself. So, thinking about the people I talked to you about, Strauss and Glass, from this first very simple study, people who report greater stigma experience also have more positive symptoms and emotional discomfort symptoms both at the same time and at 6 months later. And I think, again, a unique and key link is that, let's see if I can not tip this over. I promised Professor Roy would not fall off the stage as he had forecast, but the day is young, so the talk is young. So the key point, again, being that people who experience stigma, there is an effect that may be felt even 6 months later, independent of the impact at the moment. Okay. So let me move on to a second study which is a little more complex, but I think perhaps a little more interesting, and this is a study conducted both with Phil Yanos and David Rowe. We were interested in whether or not how does stigma impact people? In other words, how does stigma get into the sort of sense of who you are? How does it affect how you function? How does it affect your mood? And one of the major things that mental health professionals in the United States, and I suspect in Israel do as well, is that when we consult with people, we're very keen to develop a shared view with them of what's wrong, namely that they might in fact suffer from a mental illness. So if I'm the consultant, I might help Mr. Glass recognize that he has a mental illness, or I might help Mr. Strauss. Or if I'm the patient, my consultant, psychiatrist, psychologist might spend some time educating me so that I become aware that I have this illness, that there's something that I have. And our thought would be that it is perhaps that when people accept that they're ill, or when they come to recognize that they may have a mental illness, that is the point at which stigma may enter into the person's self-experience. So certainly in that way, rejecting illness could have some protective benefits. So how in the world did we go about studying this? Well, we looked at a battery of tests, which we administered again to participants. These are adult participants with schizophrenia or schizoaffective disorder. And these were assessments of awareness of illness. Do I know that I have a mental illness? They're assessments of stigma. To what extent have I encountered stigma? To what extent do I internalize these stigmatizing beliefs? We also included measures of hope. To what extent do I see a future in which I can have some meaningful experiences? And we also assess self-esteem. To what extent do I view myself as a valuable person, as someone who another person could love or care for? Am I a person of essential human dignity and value? And then lastly, we assessed, what are the social connections like? To what extent am I connected to other people? How often do I spend meaningful time in intimate social interactions? So with this group of people, we used a statistical procedure called cluster analysis, which essentially divides people into ways in which they're more alike based on measures. So we have all these different measures. Again, am I aware that I'm ill? Stigma, hope, self-esteem, social connection. And the cluster analysis divides me and the fellow participants into different groups based upon how our scores fit together. Can you find groups of people who have sort of responded in the same way to these questionnaires and interviews? And as we had suspected, we found three groups of people with this cluster analysis. The first group was a group who were relatively aware of their illness. Yeah, I think I have schizophrenia. I have this illness called schizophrenia. But this was also a group that reported in the questionnaire a lot of self-stigma. They responded to the questionnaire in a way in which they said, yeah, I think mental illness means dangerousness. Yeah, I think mental illness means incompetence. So I know that I'm sick. I know that I have this mental illness. And I think mental illness means incompetence and dangerousness. We found a second group, a somewhat smaller group, as I'll show you in a moment, who are aware of their illness. Yeah, I think I have schizophrenia. I think I suffer from this disorder, but have rejected stigma, who, when they respond to the stigma questionnaire, say, no, I don't think stigma means dangerousness or incompetence, and I think people can have meaningful lives no matter what the disability. And then we found this very interesting third group of people who said, no, I'm not ill. I don't have schizophrenia. And who are yet still somewhat accepting of the stigma of mental illness, who are willing to say, yeah, I'm not ill, but I think if you are, you could be kind of dangerous. So we have three groups of people. Again, I think I'm ill. Illness means something terrible. I think I'm ill. It doesn't mean something terrible. And I'm not ill, but it could mean something bad. And then we compared those three groups on how they reported how much hope they had, how much self-esteem they experienced, and the degree of social connections that they had. so here's a slide with a lot of numbers, which I apologize for a little bit. So you'll see our first group, people who say low insight, meaning I'm not ill, but they have mild stigma. That's 20 people. So this is out of a total of, if I can add on my feet, what's that, 70 people? Yeah, so there's 70 people, and they're divided into these three groups. Again, these are all adults who have schizophrenia. So we have 20 people who say, I'm not ill. Mental illness could mean you're dangerous. We have 24 people who say, I am ill, but mental illness does not mean anything terrible. And this third group, I have mental illness, and mental illness definitely means something bad. And in essence, what these numbers tell us is that higher scores are better for hope. Significantly more hope if you reject stigma. Although, if you reject illness, you also have some hope. So here's your problem. As long as stigma is hanging around, if you reject the illness, I got some hope. They also had even a little bit higher self-esteem than this other group. If I reject the illness, I can hope for the future. If I reject the illness, I can have self-esteem. And this group here fares the most poorly, of course. They have very little hope, and they have very low self-esteem. So these people who perhaps have come to accept that they're ill by whatever means, and who yet live with the stigma inside their bodies, see a much more dismal future. I think an important point here also, though, is this last number here, interpersonal relationships, higher numbers reflect having more connections to other people. So, a score of 23, who knows what that means, but it means essentially more connections than someone who has a score of 18. And this is done based on interview. And so here you'll see that those who said, I'm not ill, had fewer social connections than those who could reject stigma and accept illness. And also, though, very few social connections here in the high insight and the high stigma. So actually, to accept that one is ill and yet to live with self-stigma is predictive of worser outcomes, several of which are even worse than if you reject the illness. So again, it seems a poignant illustration of the earlier comments that stigma has a lasting value when absorbed by the person who's struggling with the illness. I guess I would return as an illustration again to Strauss, who, as me, the consultant, is of course nudging him and prodding him, becomes angry with me, and he uses bad words, which I'll sanitize a little bit for the sake of Dr. Rowe. He says, I'm a screwed up person. Don't you understand? I'm totally screwed up. And I say, okay, yeah, you have screwed up experiences. He says, no, I am screwed up. And of course I say, no, you're not. And he says, yes, I am. And that goes on for a long time, like in a cartoon. But the argument is, am I screwed up, or do I have screwed up experiences? Am I a schizophrenic, or am I someone with schizophrenia? And for Strauss, clearly, the illness is him. And also the illness, again, this is the young man who thought I would be frightened by the gum, who couldn't imagine having his own place. If you accept those sorts of things, well, how could you get on with your life? Why would you think about moving on or trying to manage? So, in terms of conclusions for this second study, to accept stigma and to have awareness of one's illness, there's poor functioning. To accept stigma and to deny illness might be a little bit better, but there still is relatively poor functioning. Life is still full of more social challenges. It's somehow to not let the stigma infiltrate one's being. That seems to be at the core of the group of participants in our samples who report more hope, and I think who experience more of a sense of basic human dignity as they go about their daily life. The third study is even a little more complicated, and this is a study just published in 2008. And earlier on, I was trying to make the case that people absorb stigma, and I guess perhaps without articulating it, what I wanted to tell you is that stigma becomes part of a person's story. It not only disrupts biography, but it becomes biography. It becomes identity. And so each of us believes certain things about ourselves. I'm this type of person, I'm that type of person, I have this value, I like this, I don't like this. But we're also human beings who understand ourselves as existing in stories. I have a particular father, there are things I'm striving towards, there are things I hate, there are things that I love, and you wouldn't really learn about that just by hearing about a checklist of things, that I like the color red better than green, or that my father was an engineer rather than a baseball player. But if I were to tell you about my growing up, or if I were to tell you about the clinical work that I do, which I sort of did already, you would know a little bit about me and my story and who I was. So it isn't just that I hope to do X, but I'm a particular person who believes particular things, and I've lived in different historical times. So I was raised Catholic. I had a wonderful tour of the city of Jerusalem. It had a particular meaning for me because of my story and my own battles with Catholicism and my own political ideas and the person I am, the story of the being that I am. This is, I think, where stigma penetrates the deepest and may be the most dangerous. So of course, how would you measure that? That would be sort of tough. It sounds pretty good. I mean, maybe I'm convincing, maybe I'm not. But I mean, certainly not just going to believe me because I tell you. So how could you measure whether stigma infiltrated the beings or stories of human beings? So we've tried to develop a method to assess narratives of self and illness. And we call it the Indiana Psychiatric Illness Interview. We had a contest for a really good name, and you can tell that we didn't come up with one. But it's an interview in which we ask people to tell the story of their lives and how they understand their illness, or whether they think they have an illness. Unlike other interviews, we don't ask people whether they have specific symptoms. We don't pose them problems to solve. We merely try to elicit a story. So we assess that, and then we also obtain assessments of awareness of illness. Do I think I have an illness? Stigma. And a third variable that may play a role in here, which is metacognition. It's a bit of a jargony word. I keep it in because I like the word. I think it tells us something important. Metacognition refers to the ability to think about thinking. It refers to the ability to step back and to form a mental picture of oneself and others. So we were interested in this third study and whether or not we could demonstrate, and I'll tell you a little bit more how, but whether we could demonstrate that stigma played a unique role in leading to less rich stories about self and illness. All right. So we're interested here in whether stigma was related to the richness of the personal narrative and also independent of the effects of any awareness of illness or of metacognition. So if I were to suffer from schizophrenia and I were to tell a more impoverished story of my life, you could imagine it might be just I'm unaware of my illness, or that I'm just not good at mentalizing. I'm not good at stepping back and thinking about my own thinking. So here's a slide with lots of numbers again. But let me sort of tell you the story of this. So we begin with this interview, the Indiana Psychiatric Illness Interview, and I'm the participant, and you say, can you tell me the story of your life, as if it was a book divided into chapters? And I talk about that. And then you say, do you have a mental illness, and if so, what do you think it is? And I talk about that. And then you say, since this thing has happened, whatever I call it, what's changed and what stayed the same in my life? First of all, in terms of my thinking, my feeling, my work, what's gotten different, not necessarily worse, but what's gotten different, but also what stayed the same. And then this interview continues with, you ask me, how has this interview affected other people? How have other people affected it? How does it control you? How do you control it? And what do you see in the future? And then this interview is transcribed. And so we get a relatively complex set of stories from all the human beings who enter our studies. And so this analysis is based on 51 of those stories. So again, a person is told the story then is tape recorded with full informed consent. It is transcribed and the identifying information is taken out of it. The second step then is, so that sounds like a good qualitative study, doesn't it? That's what people do in qualitative work. Well, we're interested somewhat heretically in quantifying those stories and quantifying the richness of those stories. And so we've developed a scale which we call the STAND, which is the scale to assess narrative development. And in this study, in this scale, a rater who doesn't know, hasn't heard the tape, doesn't know the person who told the story, they just see the transcript with no identifying information. They read the story and they rate on a 1 to 5 scale, how aware is this person of psychological challenges? To what extent are they an agent in the world? To what extent do they actively control their destiny? They rate on a 1 to 5 scale. To what extent does the person have meaningful social connections? And to what extent do they experience themselves as possessing basic human dignity? And so on this 1 to 5 scale, possessing basic human dignity, a 5 would be that you feel like you possess some basic social worth in your community. A 4 would be there's sort of very limited evidence of possessing basic social worth. A 3 might be I used to have some value but none now. 2, almost no evidence or mention of social worth, et cetera, et cetera. So the extent to which we talk about things like agency or social worth or intimate connection, we think of that as a continuum. People have more or less of it. And the rater then assigns a number from 1 to 5 for each of these 4 scales. And those are then summed into a total score. So you could get the highest score you could get is 20, the lowest score you could get is 4. A scale of a score, the highest score for each of these would reflect just, routine, reasonable story time about one's life. So if I bored you with the story of my life, I could tell you about the things I'm worried about and upset about. I might be connected to some people. I play some role in my own destiny, and I feel I'm of some basic human value. So for these 51 people, raters who didn't know who they were, who didn't know anything about other testing, rated how rich the narratives were. Again, we're interested in what predicts that, though. Are there ways to predict who has richer narratives or less rich narratives? So again, a rich narrative, I'm connected to people, I'm an agent in the world, I'm of some basic human value. And what you'll see here is in a series of steps, we canceled out the effects of other things on the richness of the narrative. So we thought perhaps people with higher levels of education might tell richer stories. So the 0.06 means that 6% of the variance in the richness of the story is removed if you forget about education. So don't care if you went to college, whether you got through high school. 6% is immediately removed by canceling out that. We didn't cancel out age because age had no effect. But we did also cancel out social desirability. So what does that mean? Social desirability reflects the extent to which I tell you what you want to hear. So maybe some people tell stories about hope and happiness and rich lives because they think, well, we're mental health professionals, they want to make us happy, want to please us. I recall years ago doing an interview with a young man who told me he really wanted his voices to go away, and I made the mistake of asking him why. He said it would make his psychiatrist feel very accomplished. So we very much wanted to cancel out any effects of social desirability or the wish just to please. So very simple questionnaires that give us some estimate of how much people want to please. So actually this 0.06, I misspoke. If you wipe out education and social desirability, it takes away 6% of the variance in how rich the story is. Then one problem with this interview is it asks people if they have a mental illness, and if you don't think you have one, maybe you'll tell a very impoverished story, because of course you don't think there's much wrong. 19% of the variance is canceled out. In other words, about a fifth of the variance in how rich these stories are is accounted for by whether or not a person knows they're ill. So already we've already removed a quarter of the variance, so that we're taking it totally away. So wiping those things out mathematically, it doesn't matter your education or whether you want to please, it doesn't matter whether you know you're ill or not. Then we assessed thinking about thinking, or metacognition. And you could certainly argue, and people have argued, that one of the difficulties of living with schizophrenia, or really severe and profound mental illness, is that the ability to think about complex matters is compromised. And it may be for some people. So we employed an entire new set of raters who read each of the transcripts on their own, separately, and rated how much thinking about thinking was going on in the transcript. So if I engage in a metacognitive act, I think about my thinking. If I struggle with metacognition, it's hard for me to even identify my emotions. If I do a little bit better, I can say, yeah, I feel this way, and I tend to have these beliefs, maybe they're not true. Even at higher levels of metacognition, I form complex ideas about myself and others and my relationships. I understand the independent relationships of people who have relationships with one another independent of me. And so we cancel that out. That takes away another 16%. And so you can tell already much of the pie is gone at this point. 4/10 of the pie is gone if we take away education, social desirability, metacognition, and awareness of illness. And then the take-home message, the only reason I would have told you this whole long story, is that stigma remains a potent predictor, even above and beyond that 40%. Another 10% is predicted by stigma. If you forget the rest of these things, stigma is highly related to the stories that people tell and how rich they are. But even if you parcel out the effects of many, many different things, I think you get some evidence from this rather complicated slide, I admit. You get some evidence that stigma infiltrates people at the level of the stories they tell about their lives and who they are. And certainly, what's more potent in managing your life or in figuring out what to do during times of stress than your story? So if there's an illness in your family, if there's a crisis at work, if there's a major life change, if there's think about any major thing that happens in life, or think about if you meet new people. So I had a lovely dinner with some of the faculty last night, and what do? We hung out and told stories. Stories about who we were and how we came to be the people we are. So stories help us navigate through life. I'm sure this never happens at the University of Haifa, but at Indianapolis, sometimes people become enraged where I work, and they think, I'm going to quit their job. The heck with this, or they use much worse language that I'm not allowed to use today. What the heck, I'm quitting, I'm going to be a bus driver. Or, and again, this I'm sure this doesn't happen here, but people where I work, they go home and they're so angry at their supervisor or their colleague, and they stay awake at night and they think, tomorrow I'm going to go in and I'm going to tell them off and I'm going to give them a piece of my mind. But of course, you don't do that, and we don't quit our jobs. I haven't quit my job in spite of 1,000,000 times that I promised to in my head. And in large part, I think I don't quit, or I think we don't go tell people off because of these stories of who we are. The richer the story, the richer the sense of history, the more meaningful the activity and the more meaningful the persistence. I think without a rich story, the activities of life aren't so meaningful, are they? So if someone in my family is sick, or when there's a death in my family, when we get together, we tell stories. So I would suggest that hinted at here is that one of the ways in which stigma really infiltrates and destroys the lives of people who suffer from mental illness is that it erodes story. That it creeps into the way that people tell the story of who they are, and where they're going. And it also likely creeps into family stories as well, although that's not studied here, but certainly that's likely. And that with these more impoverished stories, there's less of a way to navigate. There's less of a way to feel good about who you are. So, you know, it's worth mentioning there are a lot of limitations to these studies. These are relatively small numbers. 51 narratives is a lot of narratives, but 51 people isn't that many. This is all in Indiana, as Professor Link mentioned. I mean, it's one part of the world and one tiny part of that part of the world. And replication is really needed, and with other measurements and other methods. This whole issue of studying narratives is something I'm very interested and excited about, but it's really a beginning, and it could be easily criticized from many positions. So, you know, if there's a conclusion to these three studies, stigma is a risk factor for depression, not only right now, but in the future. It doesn't matter how depressed I am now. If I feel a lot of stigma now, I'm more likely to be depressed in 6 months. Stigma may enter through awareness of illness. If I accept I have illness and I battle with stigma, that may be the point at which hope is eroded, self-esteem is eroded, and it may infiltrate to the level of the story I tell of who I am. And I may have a weaker story and one that serves as a less effective guide during times of crisis. Here's just a brief slide to think sort of about functioning. Functioning certainly exists at the role of skills, the style with which we cope, and at the story. So 3 different ways in which as human beings I have to function. We all function. I have to be able to use the pointer as a skill. I have to be able to follow the slides. When I look at the slides and I suddenly realize that I've left out a number, I have to improvise and add the numbers in my head. It's a coping style. I could have run from the room screaming. I actually once gave a talk, and one of the members of the cabinet of the United States was there, the Department of Veterans Affairs, and I was giving the talk about coping, and I realized that it is not the updated talk, it's last week's talk. And anyway, as an active coper, I of course explained to them immediately what was going on and used that as an illustration of coping. But we have styles. We don't flee, we problem solve, or we flee more. And with stigma, you'll see at the top there, there's likely to be much more fleeing, and there's much more likely to be an impoverished narrative. And that probably is independent of the effects of other things that are damaging in the lives of people, such as anxiety or deficits in cognition. And I'm going to move along a little bit as I think I'm nearing my time. And I'm curious just to be able to share a few things with you. I think about what this might mean clinically. So it's interesting, it sounds fascinating, stories and numbers and regressions. But it seems like there are some pretty clear suggestions if you're going to interact with human beings who have severe mental illness, and you're going to try and help them to move towards health. And you've already heard this several times, but sensitivity to issues of social power. Immediately when the young man Strauss is pulling out the gum, I'm the doctor, he's the dangerous patient. If we're going to really be able to think about who he is and talk about who he is, we've got to get past that. I could tell him, no, and I do in a way in my nudging, no, you're a man with schizophrenia, no, you should have hope, no, your life is not meaningless. I could tell him all that, but as long as I'm a powerful doctor telling him those things and he's just a little itty-bitty guy with schizophrenia soaking it up, there isn't really going to be any change in the story. I mean, other people don't tell our stories for us. And in this sense, intervention and consultation, whether in group, individual settings, in the community, and offices, seems to me to be possibly a forum for evolving a personal understanding of everything that's going on, including reactions to stigma, including explorations of how did I come to conclude this and why. And I think also implied here is an appreciation of the alteration in a life's history that can occur because of these stigmatizing beliefs. As I try to imagine who I'm going to be in the future, all of these things illustrated in Professor Link's slides would seem like a ton of bricks that could come crashing down that would alter that. And it seems, again, essential that that's appreciated beyond just merely that there are symptoms or that there are deficits. And so the struggle to do this, the struggle to have a story in which stigma isn't part of it, seems to me to possibly begin, and this is based in some ways on the works of Larry Davidson, that one has to be able to see oneself as even worthy of having a story. In the case of Mr. Glass, early on when I met with him, I asked him about his life, and he's like, well, why don't you read my chart? It's like, are you lazy? You know? And in addition to that being sort of a funny comment, clearly he didn't tell his own story. Doctors told his story, and it wasn't even that interesting a story. It was sort of strange to him that I would be interested in who he was as an individual human being. Another young man, I won't give him a name because I'll forget it because I got too many fake names already from this. But, you know, he's like, so what do you get out of our visits? And I offer some thoughts about what I've learned about him. And he says, no, about the study of schizophrenics. And clearly, I somehow have come across to him as if I'm studying him, as if he's a little insect on a little pin, and I'm curious about the size of his wings, and not as an individual human being. And clearly, this young man also, not only does he have a weak story of who his life, an impoverished story, but he isn't even worthy of such a story. Why would you tell a story about him? So that needs to be important, and it has to be a story that can be shared. Mr. Glass, in the embarrassing episode where he goes outside without clothes, is a story that has some consensual meaning. It's very private and personal, but he and I can talk about it and understand what happened. So I'll rush a little because I know we're almost done, and I swore to Professor Rowe I would not go over. And was I telling the truth? I was. So, final couple thoughts. Finding stigma within narratives, it appears all over the place. It appears when people talk about what's wrong. It appears when people talk about what's not wrong. It appears when they talk about what they've lost, what they hope for, what's to be done. And maybe I'll just end by suggesting, sort of again in summary, that stigma creeps in individual lives, into the lives of individual people. It infiltrates their sense of who they are, it infiltrates their story. And that it seems to me that a neglected opportunity in the world of clinical work is for clinical work to, in addition to solving problems and offering support, to in a truly consultative way help people evolve a deeper and richer understanding of their lives and in which stigma can be rejected. So thank you for your attention.